Hi, I'm Suneet Mittal from Valley Hospital for Heart Rhythm TV, and I'm delighted to be joined by Jeff Healey from McMaster University in Hamilton, Canada, to talk about the ARTESIA trial, which was recently presented as a late-breaking clinical trial at the American Heart Association and simultaneously published in the New England Journal of Medicine. Welcome, Jeff.
Thanks, Suneet.
Jeff, this trial has been in the works for a while. Most in the EP community have been eagerly awaiting the results. Could you start off by just summarizing the concept behind the trial, the design, and what are the high-level results of this trial?
Sure. Well, as you know, it's been in the planning and conduct phase for over a decade. So, we have a lot of history here. First, with pacemakers and ICDs, we realized that somewhere around 1 in 3 patients would have episodes of subclinical atrial fibrillation lasting over 6 minutes that would develop over, 2 to 3 years after implant. And trials like TRANS and ASSERT showed that these episodes were associated with increased risk of stroke, but not the 4 or 5-fold increased risk of stroke we see with clinical AF in Framingham, but rather a lower risk, about a 2.5-fold risk. So we knew at the outset this was going to be a lower risk undertaking, but we felt the need to evaluate the risks and benefits of this type of arrhythmia because it's so common for our pacemaker and ICD patients. And as it turned out 10 years later, it became even more relevant with the development of long-term wearable monitoring. So the trial itself, we took patients with a pacemaker, defibrillator, or an implanted cardiac monitor. They had to have episodes of subclinical AF lasting between 6 minutes and 24 hours in duration. We didn't enroll anybody with longer episodes, and in fact, the protocol stipulated that if they developed such episodes, they would come off the study drug and be started on an open label anticoagulant, because we felt, the data from ASSERT especially showed that once you got above 24 hours, the risk really did go up to about 5% per year. Patients were then randomized, double-blind, double dummy to either apixaban and the standard dose for atrial fibrillation or to aspirin. And aspirin, was used as a control for a variety of reasons. First and foremost, as we found in the study, about 2/3 of individuals were already taking antiplatelet therapy at the baseline for indications like coronary disease, stents, diabetes, prior stroke, these sorts of things. So it was the most common therapy that patients were taking at the time of enrollment. Plus, as you know, back in the day when this trial was designed in North America, we were in the habit of prescribing, and indeed guidelines suggested prescribing aspirin for lower risk patients with atrial fibrillation. So as opposed to NOAA, which we'll talk about later, which was a purely European trial, this trial enrolled most of its individuals from North America. And there was a little gap between the guidelines in North America and Europe at that time. And we here still used a lot of aspirin for the lower risk patients. And that's why that was the intervention. We also, we followed patients forward for an average of 3.5 years, some of them even beyond 6 years, and looked at a very focused outcome, which is typical of atrial fibrillation trials, that is stroke and embolism. So no other composites like cardiovascular death, but really the things that are most likely to respond to an anticoagulant.
And can you summarize the high-level results?
Sure. So the high-level results is apixaban worked. It did prevent stroke, reducing it by 37% using an intention to treat analysis. And that's important because, as I said, about 1 in 4 patients developed atrial fibrillation and had to come off study drug. Another 30% stopped study drug for a variety of reasons. Many of these were due to aging and comorbidity. If you look at on-treatment analysis, the reduction in stroke was actually 45%. But, in the real world, intention to treat tends to be the way to go. And that's what we found. Surprisingly, we found that just under half of the strokes occurring in this population were severe. Using the Rankin score, they were moderately or severely disabling or fatal. And these particularly severe strokes were reduced by nearly half with apixaban compared to aspirin. Still, the absolute risk across the board was around 1.2% per year. So kind of in that gray zone of 1 to 1.5% per year stroke risk where, the guidelines suggest initiation of anticoagulation. Now, on the flip, there was an increase in major bleeding. This was looked at using an on-treatment analysis because that's very sensitive way of picking it up. There was an 80% increase in major bleeding. However, about 80% of this was non-life-threatening or let's say, didn't result in any permanent sequelae, so responded to conservative measures, including blood transfusion. About 15% of the bleeding we found required life-saving maneuvers or led to death. But there was no increase in the risk of fatal bleeding or intracranial bleeding with apixaban here. And that's the risk-benefit equation. So you've got a low risk of stroke across the board, which we knew about ahead of time. You have a hazard associated with apixaban, which we also knew about ahead of time. Interestingly, the absolute risk here was low. It was about 1.4% per year, which is substantially lower than we saw in the atrial fibrillation trials like Aristotle. But really, at the end of the day, you net out with this decision about who to treat. And I would suggest that over the next 3 to 6 months, you're going to see a lot of additional data come forth looking at traditional schemes like Transvast to help sort that out. And you can be sure there will be large subgroups of patients where there are much higher risks of stroke, where the treatment decisions will be clear. We're also going to look at echo markers, characteristics of the atrial arrhythmias themselves, and even develop novel scores around how to triage patients to therapy or no therapy. But for you and I, who are practicing electrophysiologists, I think the other key finding is, there will be people in whom treatment will make sense as soon as these episodes are discovered. But for everybody else, I think, we do have a responsibility to follow them closely because if 1 in 4 are going to go on to long-lasting or even clinical atrial fibrillation and it was only over an average follow-up of 1.5 years, that's not a lot of time. And so you do, if you're not going to treat right away, a strategy to have those patients monitored, probably with remote monitoring if they have a device, to ensure that they're looked after if they do go on to a longer episodes where treatment is required.
Well, Jeff, thanks very much for that summary. It also sounds like you're going to be quite busy over the next several months. And, I could probably spend hours talking to you about this study, but in the interest of time, I'm going to ask you to highlight just a couple of things. So the first is just patient population. It strikes me that, as you mentioned, when we think about monitoring, whether it's external or implantable, there are 2 patient populations that we are seemingly monitoring more and more. One is the population with cryptogenic stroke. And I know about 9% of the population you enrolled had a history of stroke. And also post-cardiac ablation patients, and notably those who've had atrial fibrillation ablation. I wondered what your thoughts were about how we can inform the findings of this study to guide decision-making regarding anticoagulation in those 2 patient populations in particular.
Sure. Great question. I think stroke, there will be a paper looking at the stroke subgroup of ARTESIA. There'll also be one looking at the roughly 5 to 6% of individuals who had an implanted cardiac monitor who were enrolled. Many of those had that done for stroke indication or TIA indication. Those analyses are ongoing, but suffice to say, we know that of all the Transvast factors, stroke is probably the most important in terms of predicting future events and identifying patients suitable for therapy. So I think, yes, it will be a very critical thing for the stroke population. But I think to your question, I think this now suggests for short-term monitoring, even longer-term monitoring done in the clinical arena after stroke, I think this does support the idea that treating those short-lasting subclinical events is going to make sense because we see an overall effect of 37% reduction. And it's really, what we're dealing with is a matter of risk-benefit and absolute risks. And for those stroke patients, they're going to have a high absolute risk just by virtue of having a stroke. Like the recurrence rate at 2 years following the stroke due to atrial fibrillation is in the neighborhood of 6%. So, that's a big risk. And so I think that population is going to be very suitable for diagnosis of subclinical atrial fibrillation using wearable or standard Holter technology and for early treatment if subclinical atrial fibrillation is found. The only caveat there is the longer you monitor, the longer the episodes have to be to make sense, right? But certainly the 30 seconds on a 24-hour Holter is probably game enough, and 6 minutes on a 1 or 2 week monitor is also, probably enough as well. On the other end of the spectrum, we know following successful ablation, especially in the individuals with lower CHA2DS2-VASc scores, those individuals have a very low risk of stroke, right? And, a study is ongoing looking at withdrawal of anticoagulation following. This is the OCEAN trial. Excuse me, Suneet. But we know out of the gates that those individuals are going to have a very low risk. So again, I think it's a factor of CHA2DS2-VASc and atrial fibrillation burden. We're going to evaluate that, so the jury's out. But I think if you're looking for which one of those populations is going to be the most fruitful soon, it'll be the post-stroke population.
So, Jeff, you raised the issue about the progression. As you said, a quarter of people, progress to an AF episode greater than 24 hours. At that point, they basically came off of their blinded status and were placed on oral anticoagulation. So, of course, we won't know till we have longer term data on the cohort. But it does beg the question, are we just delaying the inevitable, which is that these patients, once they've detected a short episode, they're ultimately going to need, oral anticoagulation. What are your thoughts on that?
Yeah, I think you're right. I think in some patients the decision would be to treat off the bat. In some of the intermediate groups, we're going to be interested in developing predictor models for developing persistent atrial fibrillation, right? Because if they don't have it today, but they have it 6 months from now, then maybe you should just treat initially. I can't speak to any details because those analyses are complex and ongoing. Anecdotally, what do I see in practice in our earlier trials? There are a lot of people with the subclinical atrial fibrillation episodes in the minutes to an hour range, and they come and go, right? Yeah. I think once you get into episodes that are in many hours, the likelihood that those go away goes down substantially. And, that would be my a priori hypothesis, where you're going to see patients go on, and I suspect that will be a strong predictor, but we haven't even run those analyses yet. But that would be my sense of it. But absolutely, it speaks to the point, though, that when we see this early subclinical atrial fibrillation, even 6 minutes, you have to have your eye on both things. What's the risk now? Do I treat? And if not, how soon is it going to be till that person progresses? Because many do, but not all.
So, Jeff, obviously you showed a pretty significant reduction in stroke, but it did come, at the expense of bleeding. But also, as you pointed out, about a third of the cohort in both arms, discontinued the study medication for whatever reason. So that begs the question about your thoughts about the two ongoing, alternative approaches that people are thinking about. One is this pill in the pocket approach, being tested in the REACT AF study, smartwatch guided approach, essentially to monitoring, with the notion being that maybe you only need to take the anticoagulation for short periods of time, lower your aggregate exposure to these drugs, and therefore maybe minimize the reasons you have to come off the drug. And of course, there's a lot of interest in left atrial appendage closure, as a way to, address the fact that over time, a lot of patients come off of drugs. Obviously, the study's not designed to answer that, but I just wondered, what your thoughts are about those two approaches in light of the findings of ARTESIA.
Yeah, and again, a really insightful question, Suneet. The two things really do relate together quite well. I think for the very high-risk individuals, those with a CHA2DS2-VASc score of, say, 4 or greater, I think the idea of a combination of medical and mechanical therapy does make a lot of sense. In fact, we have a large clinical trial called LEOS-4, which is about to start in the coming days even, where patients on a DOAC with very high risk of stroke are randomized to receive a Watchman device or not. And I think that does make sense because we know that anticoagulation gets stopped in about a third of people over 3 to 4 years. So these findings in this population of ARTESIA are not so unusual. You could predict that based on all the registry data that are available. On the other end, I think for the lower risk individual, probably younger, fewer comorbidities, where the stroke rates are going to be lower, there may be legs to the idea of interrupted or pill in the pocket type anticoagulation. I must say I was a healthy skeptic of this, but many discussions with Rod Passman and their group who's doing the study, and some initial looks at the data, which are coming in the coming months. We are going to fully explore this issue of burden, especially the no burden group. And that's really what we're talking about. If you're burden free, can you get a pass? And, I think there will definitely be something from ARTESIA that will inform this. And, but really, I think, is that applicable to your 85-year-old with a history of stroke and heart failure? I'm not sure that's my pill in the pocket patient. But, a 65-year-old woman with hypertension, and rare subclinical atrial fibrillation, maybe that's not such a wild idea. So again, I think the trial will help inform both of those things. And fortunately, we have nice prospective clinical trials on both those questions that are ongoing that will really, in the next 4 or 5 years, help us to answer those. But it's really the two ends of the spectrum.
Yep. And Jeff, the final question I have for you is just a word about aspirin. I mean, you started off by mentioning the differences in the two trials. Just a brief thought. Does aspirin today have a role in the care of patients with atrial fibrillation?
Yeah, sure. I mean, we've taken it out of the guidelines, right? And did it ever work? Well, it probably worked a little. If you look at the heart meta-analysis, it suggested a 20% reduction in stroke and embolism with aspirin in those early aspirin versus placebo trials back in the 1990s. You got further evidence for the antiplatelet hypothesis with active A, which was looking at combination of aspirin and clopidogrel compared to aspirin, and there was incremental benefits. So I don't think that, it's true that antiplatelet agents don't prevent stroke due to atrial fibrillation. I think that there's clear evidence they do, but again, it becomes a competing risk issue. And if you can treat with a new oral or a direct oral anticoagulant and get the same or bigger effect actually with similar or lower risk of bleeding, well, that's easy, right? You have a better choice in front of you. But I think antiplatelets do work to a modest extent. But really, the reason they found their way into the trial is because patients had indications for all the other reasons: diabetes, heart attack, stent, prior stroke, and these sorts of things. What does surprise me, and I'll put it out there for this trial, I was surprised by how many, I would have thought, we're dealing with an older population, lots of vascular disease. I thought that most strokes here were going to be mild. And actually looking at older observational data, I would have thought that we'd be dealing with the Rankin 1, 2, and 3 strokes, the mild end of the spectrum. And, in the aspirin arm of this trial, ARTESIA, 45% of the strokes were moderate or severely disabling or fatal. Still in absolute terms, not a huge number, but in terms of the types of strokes people had, they were big. And those were the type of strokes that anticoagulation reduced most in this trial. So, we're still learning a little bit about stroke subtype. It's not a precise science, but it seems like those big strokes that we think are more likely to be embolic in nature were the ones we took down with ARTESIA. So lots to learn here. Aspirin, I don't think, to answer your question, aspirin, I don't think has a primary role in the management of atrial fibrillation per se. I think there are better options for most patients. If you have to be on dual antiplatelet therapy and you have a CHA2DS2-VASc of 2, is that okay for a while? Probably, right? I mean, it's probably preferable to triple therapy. But, for chronic indications, we know that adding aspirin or other antiplatelets on top of anticoagulants gives you nothing except a doubling in the bleeding risk. So I think there are better choices for most patients, but they probably do reduce stroke to a modest effect.
Perfect. So, Jeff, obviously, this literature more than most, and, you've already mentioned NOAA AFNet, ARTESIA is now published. We've heard, top line results from Arcadia. You mentioned Ocean. So maybe just a final, summary to the audience as to when we think about this topic of subclinical AFib and oral anticoagulation, what do we know now, and what are you looking for, forward to in the next few months, the upcoming year, in terms of what more questions we hope will be answered, so that clinicians, when they're in the office, will have a better idea on how to really address this issue. Do I anticoagulate or don't I anticoagulate?
Sure. So starting with NOAA. NOAA was the other trial in subclinical atrial fibrillation, atrial high rate episodes, presented back at the European Society meeting. It was a neutral trial, showed no benefit in terms of embolic events, but with an increased risk of bleeding. On Sunday, we did publish two papers. The second was in Circulation, a meta-analysis of these two trials. And the conclusions really are that ARTESIA and NOAA showed the same result. NOAA was just a smaller trial with far fewer events, but when you lay those studies together and analyze statistically, there is no significant heterogeneity between the two studies in terms of strokes prevented, bleeds caused, or even the composite outcome. And in fact, on meta-analysis, that NOAA composite of stroke, systemic embolism, cardiovascular death, MI, was actually modestly but significantly reduced by 15%. So that's the take home. The other take home of the meta-analysis is, we worked directly with the group from NOAA, very much both invested in this question. We have ARTESIA calling this subclinical atrial fibrillation, NOAA calling this atrial high rate events. Everyone likes their own term, of course, although after the results of ARTESIA, to call it subclinical kind of implies that it's not important. And so one of the take homes of that meta-analysis was proposing this all be called device-detected atrial fibrillation, because it is atrial fibrillation. Causes stroke like atrial fibrillation. It responds to anticoagulation like atrial fibrillation. It's just picked up by a long-term monitoring device. And that lends well for discussions of other things like wearables and such things. In terms of where else does this go, I think in the embolic stroke of undetermined source, I think, like you say, we're still monitoring here. So, the three ESUS trials were all negative. I had high hopes for Arcadia being in a rich population with this atrial cardiopathy. However, it didn't pan out as predicted. There are obviously analyses ongoing to tease some learnings out of that, but I think we are still left with monitoring here. So the questions really will be how much and how intensive will the monitoring be? But certainly right after the stroke, a period of continuous long-term monitoring makes a lot of sense. In the United States, perhaps in certain jurisdictions, even implantable devices make sense here too. In terms of atrial fibrillation screening, that's a bigger question. I think here it's all about absolute risk, right? You're going out into populations that don't have a problem. You're looking for trouble, unlike a pacemaker where you're confronted with trouble. Here, I think if you're going to use continuous, it's going to be in the highest risk individuals, because if you're just screening average risk 65-year-olds, the insensitive tools like handheld ECGs twice a day for 2 weeks make a lot of sense, just because the burden of AFib you're going to pick up with those devices is going to be higher, because they only measure a few minutes of screening over the period of 2 weeks. So it's I think that's for screening and for ESUS. And what was the final population you were curious about?
Ocean,
Ocean, yeah.
Ocean a little bit, yeah.
Yeah, so Ocean, it's in its follow-up phase. It is enhancing its power by using MRIs to assess outcomes, so looking for covert stroke, as well as clinical events. We all suspect that will have a lower stroke risk because of the selection of patients for atrial fibrillation ablation. We tend to like lower risk patients, but that is ongoing to know if we can safely discontinue oral anticoagulation. And I suspect, don't know, but I suspect, we'll be confronted with similar quandaries that we have here with ARTESIA, which is, what to do if, there is an effect or there isn't an effect and the stroke risk is low. Is there a threshold below which, the stroke risk becomes acceptable to people? But I think it's a very important trial, Ocean, because, again, the metrics we use, whether it's atrial size, CHA2DS2-VASc factors, how do they actually roll out post-ablation? You know, is a 4.6 centimeter atrium after you've ablated the same thing as one de novo? Are the CHADS-VAS factors the same? Are there other factors that we don't consider at the moment? So I think it's a very important trial that'll help define this, increasingly common dilemma of what to do after you think you've done the job.
Perfect. Well, Jeff, thank you very much for spending a few minutes with me this evening. Obviously, a big congratulations to you for bringing ARTESIA over the finish line. We've learned so much, and yet after every one of these trials, I'm left thinking we have so much yet more to learn, and already thinking about what your next big study is going to be to try to help us, after a CERT and ARTESIA. But I think there'll be lots and lots to talk about. And again, I think our viewers will really appreciate the insights you've brought to this discussion. So thank you very much.
Thank you. It's my pleasure.